Welcome. You've been introduced to CF care when there are no guidelines. I'm presenting first and on the topic of Elexa-Teza-Ivacaftor, what the AE. My name is Megan Fleischman and I am at the Adult CF Center at Froedtert and the Medical College of Wisconsin. And I am presenting to you today from Milwaukee, Wisconsin. I have nothing to disclose. And the learning objectives are to have an idea of review the evidence available on adverse outcomes of Elexa-Teza-Ivacaftor and Ivacaftor triple combo therapy, as I will refer to it often as triple combo therapy, to propose other possible adverse effects related to the triple combo therapy, and then to discuss a little bit about possible management strategies for some of the adverse effects that are out there. The audience is presumed to be familiar with the following information. So the phase 3 trials in regards to triple combo therapy. So trial 102 and trial 103 are how they're commonly referred to. Also having a basic understanding of what the prescribing parameters are behind elexacaftor-tezacaftor-ivacaftor triple combo, as I will allude to it throughout the presentation. And then to just kind of have a general familiarity with the fact that the modulators have common adverse effects that you see across them. So LFT monitoring is required for all of them due to LFT elevations that have been seen in clinical trials for all of the modulators. Blood pressure has been something that's been consistent across the modulators and was looked at for this medication and found to be relatively similar in the sense that you do see some elevations, usually not drastically significant or necessarily clinically significant, to some degree clinically significant, but manageable. And then ivacaftor having the risk of cataracts in the pediatric population, and therefore, since it's a component of all of the medications, having that indication for monitoring. So when we think about a new drug, we think about, well, how long have we really had it on the market? Not very long, because it's a new drug. So there's a lot of implications for safety profile, and sometimes I've heard other clinicians be hesitant to use them. In this case, we're not, because of great efficacy outcomes that we've seen with the triple combo therapy. But looking at our population in a little bit more detail, I wanted to get you an idea of the exposure the patients have had as far as a lot of the information and patient reports that I pulled from. So what I looked at was this multidisciplinary review. And the multidisciplinary review was something that was done by the FDA in their process of approving the drug under the new drug application. So the information comes from the trials that were out there, and the patient exposure comes from that as well. So when we look at our trials, we have trial 102. And that trial, as a reminder, is the one where the company looked at the triple combo therapy versus placebo for patients who were heterozygous for delta F508 with their other mutation being minimal function mutation. That group, 202 of the patients were exposed to the triple combo therapy and was a duration of 24 weeks. Trial 103 is the population that is homozygous for delta F508, and therefore the triple combo therapy was compared to the tezacaftor-ivacaftor combination, and that was for 4 weeks, and the study population that was on the treatment arm was 55 subjects. And then there is the study 105, and that had the remainder of patients, or the patients rolled into it from the previous studies, and then the other ones, the remainder from the control arm, made up that 251 patients that were additionally put on the triple combo therapy. So the duration of that is 96 weeks, as far as I understand. It's still ongoing for some patients, and the data at the time of the submission of the new drug application went through July 10th of 2019. So that was a shorter time frame. So as you see, instead of my time frame ending at 96 weeks, we see really more of a 48-week ending for the time frame. Nothing was beyond 60 weeks at the point of the submission. So if we look at this, we have several that were under 24 weeks, but I believe they were pretty much approaching the 24-week mark. But majority of our patients fall right in between that 24 to 48-week duration as far as how long they've been exposed to the triple combo therapy, with some of them a little over 10% being on it for greater than 48 weeks. So that gives you an idea of our population exposure from the different trials and studies. So then what do we find as far as adverse effects? So to orient you to this slide a little better, you can see that down below I have footnotes in regards to the asterisks, and that is indicating the adverse effects that were reported as common in the trials. And so with them being reported as common, those are going to be ones that if you're looking at the studies that are out there, 102 and 103 as they're published, that's where you're going to see the side effects listed. In addition, there were several other adverse effects that were brought up in the multidisciplinary review, and those are listed here as well. And they also, I think some of them were mentioned in the paper, just not necessarily in a table, but in result discussion. And then finally, at the other footnote I have here is in regards to side effects that weren't necessarily reported in the trial or the new drug application, but really were ones that I came across, whether it be talking to colleagues, talking to Vertex themselves, talking to patients and getting their experience. So just different reported adverse effects. And it didn't necessarily encompass, well, no, I did encompass all of them. I forgot. So looking at this as all together, I'm going to give you a second to kind of digest it and pause if you need longer. My point, though, today is to not spend a ton of time talking and reading through all of these adverse effects that have been reported. What I'd like to do is dive into some that have a little bit more information behind them. So the ones I'm focusing on have some case reports or management strategies that I thought would be worth discussing today. We'll start with the adverse effect that we see we do see across the modulators, with the AST, ALT elevations being consistent with that. I also want to dive into a little bit more of the information about elevation of labs, but then also going into this idea of some biliary complications in addition to the liver complications. So what did we see in the trials? As far as trials go, there were serious adverse effects seen in trial 102 and study 105. With trial 102, they did have one patient drop out, and that was because of their development of portal hypertension. Didn't seem like the multidisciplinary reviewers were very convinced that it was an exact cause from the drug, just considering the patient had a history of hepatic cirrhosis, but it did need to be reported, and it was a reason the patient had to stop the triple combo therapy. In addition, they reported that 2 of the patients did have to temporarily hold the medication due to ALT elevations. 103 did not have any patients that needed to interrupt therapy or discontinue therapy. Granted, we also can take into consideration it was only 4 weeks long. And then from the study 105, 10 patients ended up requiring treatment interruption due to elevated LFTs. So I did break down for you here too the difference between the groups that were previously on placebo versus tezacaftor-ivacaftor versus on the triple combo prior to entering into the extension trial, study 105. And you see with the placebo, 5 patients developed it with 1 patient dropping out. Tezacaftor-ivacaftor, 1 required holding the dose. And then with the triple combo, 4 patients ended up having to hold the dose, and 2 of them ended up dropping out of the trial. So when we dive into the labs a little bit more, you do see a trend where it is higher in the triple combo group, not really having statistical significance here. I recognize that with the asterisks, there is no notation as to what the asterisk means. It does not mean statistical significance. It's to indicate that there was one person who simultaneously had elevated AST, ALT, so greater than 3 times the upper limit of normal, as well as elevated blood bilirubin, so greater than 2 times the upper limit of normal. The report with that patient was they ended up getting diagnosed with acute cholecystitis and had a cholecystectomy. And then after liver function tests were able to resolve and get back to normal or baseline, the patient was able to be restarted on triple combo therapy. So we did see that one case in the trials, and that came from the extension trial of a patient having biliary complications. But Dr. Saferstein and colleagues actually started seeing a trend as far as biliary complications went and decided to put out a case report on it. So she worked with another center, and 2 CF centers ended up putting out this case series stating that they have approximately 500 patients on the triple combo therapy. And they reported on 7 cases who had different symptomatic and biliary related complications. All of those patients who were included in the report had pancreatic insufficiency and were on pancreatic enzymes. And then all of the patients who had a history of biliary disease were asymptomatic when it was diagnosed and found on CT in the past. As far as the outcome of the treatments, one patient was able to continue treatment throughout. The other ones stopped, but were able to resume full dose without complications at the time the literature was supported, or was at the time the literature was submitted to be put into publication. So looking at the patients a little bit more, you see that there really isn't huge trends across the patient population. The patient group does seem to look a little bit older from a CF patient standpoint. No real trends with gender or really previous modulator. Likely the representation is more so related to what we typically see as the breakdown of delta F508 making up majority of the mutations in our CF population. So then as far as history of biliary or liver disease, CF-related diabetes, again, no clear trends. It kind of was split to have both. Elevations in ALK-Phos, AST or ALT, bilirubin, again, nothing that stands out as, oh, if this happened, then we tended to see acute or chronic cholecystitis. So the one patient that doesn't have a diagnosis of the type was the one who continued on treatment throughout, and they did not end up requiring a cholecystectomy. The remainder of the patients all had cholecystectomies and were diagnosed with chronic or acute cholecystitis. The patients who were diagnosed with chronic cholecystitis did have evidence of a gallstone formation as well. So as far, again, to kind of review the conclusions, the patients did have cholecystectomies despite discontinuing therapy, and they all resumed therapy post-cholecystectomy for the ones who did have it. For elevated liver enzymes, we do again see that trend where there is some elevations with the inclusion of direct bilirubin being at risk for being elevated, and so recommendations are consistent and a little bit added to in the package insert as far as when to discontinue or hold triple combo therapy. But then once we've held it and labs resolve, what do we do thereafter? And it really kind of is going to depend on the patient, but different ideas have been put out, such as maybe we resume and have closer LFT monitoring, maybe we use different dosing, or like starting at a smaller dose and gradually increasing. So I want to move to another topic that I'm discussing that's driven by a case series, and that's testicular pain. As far as trials go, there weren't any reports of reproductive complications with the use of the triple combo therapy. However, once put into the general public, some clinicians were noticing across centers that they were getting reports of testicular pain. So 5 centers, CF centers, put out a case series on 7 male patients between the ages of 17 and 39 who reported experiencing testicular pain within the first week of starting Trikafta for the majority of them. And then with those patients, 5 of them, or a good majority of them, had that testicular pain resolve within a week of its onset. 2 others had a longer duration, but also had it resolve within the first month of the onset of testicular pain. 1 patient did end up getting treated with an antibiotic for arthritis. And ultimately, all patients were able to resume full dose of the triple combo therapy. 1 patient ended up holding for a period of time, and then another had a reduced dose, but then were able to resume it and were tolerating it fine at the time the information was submitted for publication. 6 patients, so the ones that didn't have the diagnosis of arthritis, did not have any other explanation for their testicular pain except for that correlation with starting the triple combo therapy recently. As far as implications for practice, my kind of takeaways from this is most of my patients, pretty much all of our male patients, are on the triple combo therapy. So not really sure that I'd be going back and discussing their history of testicular pain unless I was just curious, as a good portion of them, or I think all of them that are on it now, have been on it for well over a month. As far as incorporating this into practice, it is a possible trend, and it could make sense to use this as a counseling parameter to say, you may experience this, it is self-limited, this is when you should contact us. Now I want to get into a bigger side effect that we've seen as a large component, probably the most commonly reported side effect with the triple combo therapy, and that's rash. So keeping in mind with rash, it is affecting the skin, and there are other items in this that were reported as side effects related to the skin. So acne, and hard to know, is the acne more of an acneiform type reaction, more related to a rash, or is it genuinely acne? Would require diving into the cases a little bit more. And then photosensitivity, which sounds like that may be a side effect that's coming out with the updates and information from Study 105. So more to come on those, but we're going to focus really in on rash. So in general, rash is very mild to moderate with the triple combo therapy, resolving relatively quickly, not having a huge burden on a good portion of patients. At least that's been my clinical experience, and with the idea that you'll see just the amount of patients who report severe rash versus having just that mild to moderate severity of a rash. So when we look at the trials, we have the median time to onset is around 12 days. And you'll notice later when we discuss some of the rashes reported as more severe, they did kind of fall around that 12-day mark. But mean was roughly 34, 35 days, give or take several days. There were no reports of Stevens-Johnson syndrome in the trials. And then I did flip-flop on you a little bit here. Trial 103, again, that's the homozygous for Delta F508, where it's the patients on the tezacaftor-ivacaftor being compared to the triple combo. That found 2 patients in each treatment arm to have developed a rash. All of them were able to continue triple combo therapy, with 1 patient in the triple combo, or I guess all of them were able to continue therapy because 2 of them were in the tezacaftor-ivacaftor arm. But with the triple combo therapy, one of the patients did end up stopping their hormonal contraceptive. So then trial 102, the Hetman trial, where it was the triple combo versus placebo, about 11% of patients reported that they developed a rash when they were in the triple combo arm, and one of the patients in that treatment arm ended up dropping out due to a severe rash. So trial 102 is the one I want to go into more details of, because that's where a lot of our subgroup information comes from as far as recommendations that we see in the package insert. So patients who had any rash, we already discussed, about 11%, and then placebo was about 6%, 6.5%. Serious rash, one patient in the placebo group ended up reporting developing a serious rash and was able to continue therapy, whereas 3 in the triple combo and 1 did end up discontinuing. 2 of the 2 others just held therapy and then resumed it. We do see a higher percentage, so a higher number of females than males out of the total reported, but then just a higher percentage relative to baseline. So although incidence of drug rash tends to be higher in females, it's considered a risk factor for drug rash, we do see that relative to the proportion on placebo, it is higher. And it has been proposed that possibly hormonal contraceptives are related to that. When you look at it, you could argue, well, there's 8 people out of the 16 that developed the rash that were on hormonal contraceptives, so about 50%. But when we really look at the breakdown of the females on hormonal contraceptives, you see that bigger difference between the portion of patients. So 9.4 in the placebo group who were on hormonal contraceptives end up developing a rash versus about 20.5% who were in the triple combo arm. And then again, comparing it to the proportion of patients that were not on hormonal contraceptives. So 13.6 of those patients in the triple combo therapy arm were not on hormonal contraceptives. That's quite a difference from 20.5. So that's kind of the rationale behind that. And then the extension trial just added more patients onto it. Again, a good portion of them being female, not necessarily described here, but you'll have to take my word for it or dive into the literature. But if you look at, I broke it down again for you for the previous trial arms, so thinking about patients coming from placebo, that did make up a good portion of the patients who developed the rash in the extension study. And then the Teza-Ivacaftor arm contributed, and the triple combo arm being continued also contributed to the number of patients with treatment interruption. And then in the triple combo, that one patient did drop out in study 105. So again, I've kind of mentioned this before, but rash characteristics vary. So what are we seeing as far as our rash characteristics? Well, we have a variety of female ages, whether they're on hormonal contraceptives, types of hormonal contraceptives vary. 29-year-old male, 13-year-old female not on a hormone. Some people are reporting several patients that were like 2 males, 3 females, 5 males, a brother and a sister. The sister wasn't on hormonal contraceptive. So just seeing a variety of ages and the spattering of gender kind of being consistent with that. And these are characteristics related to the severe rashes that were reported, because that's what I'm hearing from colleagues, and then that's what was pulled out and discussed in more detail in the multidisciplinary review. So looking a little bit more, again, seeing it kind of around that first 2 to 3 week time frame where it develops, and just various descriptions of it that you guys can probably read faster than I can read to you. Sometimes palms were included. Pruritus was often a huge contributor to decreased quality for patients. Spreading, so a lot of that classic drug rash where it starts on the torso and then spreads to the extremities, some patients experiencing it on the face. I will point out the mild peripheral eosinophilia, so some lab tests did show evidence of some type of immunologic response. So what do we do for a drug rash evaluation? Looking at, is there likely a drug reaction going here? So we had a patient that reported a rash and we had her treated topically, but then upon further conversation with her after the fact, she mentioned, well, I did have some sand in my sock when I was playing volleyball, so that could have caused the irritation as well. So kind of thinking from that standpoint didn't really make a difference in our management of it, and it did resolve relatively quickly in that patient's case. But the other side of looking at things is it a drug-induced hypersensitivity or immunologic reaction? So thinking along the lines of if there's an immune mechanism behind it versus a non-immune mechanism. And so descriptions of, well, your immune mechanism is going to be potentially IgE mediated. Granted, a good number of the descriptions that I've read didn't really suggest IgE mediated type rashes. Delayed cell mediated seem to better align. So along those type 4 reactions where there was a drive by the T cells causing the reaction. And then the non-immune mechanism, so going along the lines of side effects and various other definitions that kind of mimic an allergy but aren't necessarily that. And then with the immune mechanism, if you're highly suspicious of that, there are options for testing for that. So that could be a way of looking at things, confirming through tests. Usually we probably have a dermatologist or allergist involved at that point. And then as far as management goes, we want to look at, well, if it's more immune mediated, those first 2 options really aren't very good options because we want to have our patients on therapy for long term and have them on it every day. However, maybe considering, do we need to do some kind of desensitization? Or is it more of a non-immune mechanism or that side effect profile, and treating the side effect, treating the pruritus would be sufficient and it will resolve on its own, modifying the dose if needed, making sure that in both cases we have patient education involved, and then we could also consider graded challenges, which kind of mimics a similar idea of potentially desensitization. So I do want to go into a little bit about desensitization with you, as there was a patient case put out where a desensitization protocol was employed and successful. So the patient case was an 18-year-old female who reported a rash with starting Elexa-Teza-Ivacaftor, and then the rash reoccurred upon re-challenge. Then when Testicular came out, she was tried on that and again experienced a rash. So because ivacaftor is in both of the products, they decided to do a gradual dose increase through dilutions of ivacaftor over 10 days. And the reference here includes a more description of how they went about doing that over that 10-day period of time to ultimately get to the 150 milligram dose. Once the patient was at the 150 milligram dose, 3 days later, they added on the tezacaftor, and the patient tolerated it and did fine and was, at the time of the case being submitted for publication, she was on it and tolerating it for 5 or 6 months. So key takeaways from that were the fact that we're probably inducing a temporary state of tolerance just with the way her rash presented. It seemed either one of those type 4 reactions or just something more severe where they needed to get her to a point of tolerating it. So with it being a temporary state, when we think about antibiotics, for example, each time you desensitize, or each time you put the patient on an antibiotic they have a problem with, you need to desensitize them each time. So the idea is counseling the patient that she needs to remain adherent to therapy so that we don't have a lapse in therapy, because likely a desensitization protocol would need to be employed again. And then the other component that we don't really have an answer for here is we are seeing, as the triple combo therapy has a pretty decent amount of a rash with it, could elexacaftor have different implications where would we be able to just add that on like tezacaftor was done, or would we need to do a gradual increase of that dose as well? So that's kind of an unknown at this point. Granted, there may be some colleagues out there that have a better idea of this, and it may just kind of depend on how your patient presents and what their history of other modulator use has been. So management in general, more simplified than going to the point of desensitizing. For the majority of people, if the rash is not tolerable, you could follow package insert suggestions where you hold the elexacaftor-tezacaftor-ivacaftor and hold their hormonal contraceptive if they're on that as well. And then the package insert suggests to retrial the triple combo once the rash has resolved. And then if no rash appears at that point, you could consider retrialing the hormonal contraceptive. Now, again, that's got to be kind of individualized because there's some patients that you may not want to be stopping the hormonal contraceptive for, or it might not be as easy as not taking a pill. So again, thinking about the fact that most of the reports, the rash was treated while the patient continued on the triple therapy throughout that time frame. So ways of treating it that have been put out there, lots of proposals of higher doses or tapered doses of corticosteroids. Antihistamine use was often reported, with diphenhydramine often being a first line, but then hydroxyzine and cetirizine being part of the regimens as well, with cetirizine being that second generation and potentially less drowsy. Some of the H2 receptor blockers, so the H2 antihistamines, were also brought into some of the regimens in combination with them. And then depending on how the rash is presenting or how severe it is or how localized it is, topical emollients or menthol or camphor could be used as well. Topical steroids would also be considered. So that's management of the rash, and that's our big description. I do want to discuss a little bit of other management that have been kind of thrown out there, and from anecdotal experience, or from anecdotal evidence, it's been successful. So switching dosing times has been shown anecdotally to be effective for management of headaches, abdominal pain, specifically abdominal pain associated with timing of dose, so occurring within an hour or a couple hours afterwards, fatigue or mental fogginess, and then kind of on the opposite end, insomnia, or even feeling more activated on the drug. So switching the dose, meaning that typically we say, okay, take your 2 orange tablets in the morning and your 1 blue tablet in the evening, but we just ask to have the patients switch that, where they move the blue to the morning and the orange in the evening. And clinicians have reported that this seems to work for our patients. The other option is we could potentially start with a lower dose. So maybe we tried switching and it didn't work. Maybe we switched our patients to a lower dose, or have them hold it, see if the side effect resolves, and then resume at a lower dose, maybe 1 orange tablet in the morning, and then gradually add on an additional tablet on a weekly basis, for example. Other times that could be as if the dose was held and we're a little hesitant because of the severity of the reaction to just jump back into the full dose. And then modulator-induced LFT elevations. I kind of alluded to this earlier, but in addition to patients having to pause therapy for or hold therapy for LFT elevations on the triple combo, maybe patients who've had a history of LFT elevations and issues with the other modulators, this could be used. So they had elevations with the other modulators, maybe we want to proceed with a little more caution with starting these doses, and closer monitoring, of course. So that's what I have for you. Overall, the triple combo is well tolerated, with most of the adverse effects being self-limited and in the first week. So I don't want us to lose that part, since we dove into a lot more individual case-based information. Counseling upfront is important to manage expectations. We are still in that first 2 years of collecting data for patients who are on the trial, and really the first year for collecting safety information for the general population. So keep putting information out there. If you're coming across side effect trends, or you find a consistent way to manage a more severe adverse effect, report it or write it up. We'd love to hear it. And with that, I'll leave you with this lovely table of the different adverse effects reported, and that'll allow us to transition to the next speakers. You have some excellent presentations coming up. Thank you.
Thank you for joining this on-demand session for the North American CF Conference. Today, Lauren Kormelink and I will be discussing making the connection, pharmacy services during a pandemic. We have no relevant or financial disclosures as it relates to this presentation. The objectives for today are to review the pharmacy care model at a pediatric and adult cystic fibrosis care center, outline the care model response to the pandemic to ensure continuity of care, and lastly, discuss pediatric and adult cystic fibrosis care center identified best practices in the setting of a pandemic. The Pediatric and Adult Cystic Fibrosis Care Center is located in Lexington, Kentucky. It is a CF Foundation accredited center with 140 pediatric patients and 160 adult patients as of 2019 registry data. This care center primarily sees patients from central and eastern Kentucky, but we do have patients that come in from Indiana, Ohio, West Virginia, Tennessee, and Virginia. So we really are pulling from a large geographic region. We're very fortunate that at our care centers, both in the pediatric and adult, it is a multidisciplinary care team with physicians, advanced practice providers, nurse coordinator, dietitian, respiratory therapist, social worker, and a pharmacist, each dedicated to both care teams. We're first going to look at the pediatric pre-pandemic care model. Before SARS-CoV-2 pandemic really hit the United States, our flow looked like Mondays mornings, we had inpatient team rounds with the entire care team. In the afternoon, this was really protected office time for clinic staff, the nurse coordinator, dietitian, other providers. Clinic did span Tuesday through Friday, and you can see the breakdown with the number of providers in morning and afternoon clinics. At most, at any given time, we had three providers in a half-day clinic session. As the days allowed, Tuesday through Friday, the pharmacist did attend inpatient rounds with the attending on service to ensure continuity of care for those patients that were admitted with cystic fibrosis. Looking at once the patient arrives, what their visit looks like is, of course, they were registered with clinic staff. Just to ensure appropriate infection control, all of our pediatric CF patients were roomed immediately. They were triaged with a dedicated CST in our pediatric space. They then visited with the respiratory therapist, and of course, if they were 5 and older, they did perform spirometry. At that time, the social worker would then pop in to see the patient, whether doing a mental health screen or identifying any other barriers or concerns that the patient and or caregiver may have had. Due to some of the overlap in questionings, reviewing drug therapies, specifically like pancreatic enzymes and vitamins, the dietitian and pharmacist, we would go in the room together to really optimize that visit time. Next, the provider would see the patient. The nurse coordinator would then see the patient to do the discharge paperwork, collect the sputum culture. If laboratory work was needed, we're very fortunate at the University of Kentucky that we do have pediatric dedicated phlebotomy and ensure, again, from an infection control standpoint, they actually come to the patient's room to collect those labs. And then the patient is discharged. So for these visits, it could be upwards of an hour, hour and a half, 2 hours or more, depending on the touch points for all of these disciplines and if laboratory work was needed. Looking at our appointment structure pre-pandemic, the advanced practice provider visits were any 40 to 60 minutes. We're very fortunate that our nurse practitioner does have transition visits. These are scheduled on Thursdays, typically for our adolescents 15 and older, as we're starting to prepare them for their transition to the adult world. For our physician visits for CF patients, those are 40 minutes in length. As I highlighted on the previous slide, each multidisciplinary team member will see the patient at every routine or transition visit and report any of those concerns, needs to the provider so they know what to expect when they enter that room. If we are seeing a sick visit in clinic, it is limited just to a few care team members, the respiratory therapist, pharmacist, and potentially the dietitian if there are those nutritional concerns for these patients.
For the adult side, our pre-pandemic care model, it did differ a little bit from how our pediatric clinic operates. Of note for us on the adult side, our pulmonary clinic is separate from our cystic fibrosis clinic. So we are dedicated in our side to just seeing the adult cystic fibrosis patients and not other intermixed asthma and COPD patients. Every Monday, we would do inpatient team rounds in the morning. So all of the multidisciplinary team members would round on the patient. We also repeat that on Friday mornings just to kind of close the week and make sure we have any transitional activities completed prior to going into the weekend. Our main clinic days were Monday and Wednesday afternoons. And at this time, we would see as many as sometimes 14 patients or more in the afternoons on Mondays and Wednesdays. On Tuesdays, we have our team meetings in the morning, and then after that would focus on seeing patients who are acutely sick or who are following up on home IVs or from a sick visit. Thursday mornings are dedicated to our Burkholderia positive patients, just to try to have an extra layer of safety in keeping those patients more isolated from our patients who do not grow Burkholderia. And then again on Thursday afternoons, if we had last minute sick add-ons, we could put them there. For the most part, our Friday afternoons would stay open, but we are always willing to add someone on if we think they need to be seen. As with the pediatric team, as the pharmacist, I do try to round with our pulmonary CF consult team on inpatients at least 4 to 5 days a week, just as time allows. And our workflow, as soon as a patient arrives into clinic, is similar to the pediatric team. So our patients will check in at a front desk of our clinic and then immediately be roomed and vitals obtained by our CF RN. Next, the patient would be moved to the PFT room to have their spirometry performed, followed by individual multidisciplinary consults, and then lastly, the provider visit. For our appointment structure, our advanced practice provider has a 1 hour time slot, and he would see about 4 to 5 people per half day. And our physicians have 30-minute appointment time slots and would see anywhere from 8 to 10 patients per half day. You can see we would have up to 15 patients in a half day. Each multidisciplinary team member pre-pandemic would go in individually to see the patient prior to the provider, and then we would just report any concerns or extra needs to the provider prior to them going in to see the patient.
So in the state of Kentucky, when we're really preparing in light of the pandemic, really getting started, constantly monitoring, we did want to ensure that there was appropriate continuity of care for our CF patient population. One of the things I did want to highlight is that telehealth services were not very robust at our institution prior to this COVID pandemic. So our administrative group really hit the ground running to build these services in a short period of time. So we're very fortunate that a lot of evidence has been published in the recent months to kind of outline from a pharmacy services standpoint those telehealth things. Just to bring us all up to speed, the United States Health Resources and Services Administration really defines telehealth as the use of electronic information and telecommunication technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. And it's great that pharmacy really, and pharmacists really provide a role within this for continuity of care, especially for our CF patient population. I think ongoing to support the telehealth services, whether it's for CF or other healthcare needs, is those regulatory changes are constantly being evaluated and updated, whether it relates to telehealth services in and of themselves, the originating site of care, what technology is available, whether it's a Zoom meeting or some other platform that institutions may be using, and of course, patient eligibility. We really had to evaluate this as we touched on our CF care centers, both for adult and pediatrics. It is a large regional referral center, not just patients from Kentucky, but those from West Virginia, Indiana, Ohio, even Tennessee. So looking at our patient eligibility was a key criteria. And for that telehealth at our institution, they had to be residing in the state of Kentucky for billing purposes. So there's key components from a telehealth standpoint, and this really models across our institution, not just in the CF patient population, those components of a visit. We all receive training in telehealth services. We work to identify eligible patients for visits and work with those patients and or caregivers to agree upon this mode of a visit. Of course, using the HIPAA-compliant technology with audio and visual capabilities. It was secured, tutorials were provided, and each of our providers in the pediatric world, and similarly on the adult, had their own dedicated Zoom provider line. And even with the HIPAA-compliant, Lauren and I are very fortunate that we have our own Zoom appointments that we can schedule that are HIPAA-compliant for our patient population. The patient and the team will be in a secure location with access to that HIPAA-compliant technology. And I was very fortunate with the telehealth services that I was able to just kind of reserve a clinic room to have these visits. And I believe Lauren had a very similar model, which was very fortunate that we had that space available. Our nurse coordinators consented the patient, completed the identification verification, and really started these visits out to get the ball rolling. And lastly, ensuring that appropriate documentation at the completion of the visit to, again, allow for billing of these services and that these patients were in the state of Kentucky. I don't think any presentations complete without looking at COVID-19 in the state of Kentucky and looking at our case numbers as the pandemic has progressed. So really in early March, very few cases, but I did want to highlight April 1st of 2020, there were 89 confirmed cases in the state of Kentucky. This was really when there was a lot of movement at our institution to do what we can to keep these patients safe and healthy. What can we do to leverage these telecommunications and telehealth services to keep these patients safe and healthy? I did want to bring your attention as we fast forward, you can see it really is a fluctuating curve depending on case numbers that are being reported at any given time. But the most recent data that we have that's published is at the end of August, there were 364 confirmed cases of COVID in the state of Kentucky. Really draw your attention to this figure because it really does impact when we look at our telehealth versus inpatient numbers for both the pediatric and adult care centers. So transitioning specifically to the pediatric CF care model in the pandemic and kind of our current state as well. So I work with our information technology and administrative group to really get a sense of what are our telehealth numbers. As you recall in the previous slide looking at COVID cases in the state of Kentucky, in kind of that February-March period, we didn't really have any cases. April 1st saw that there were 89 confirmed cases in the state of Kentucky, and this was really our pivot point to where we really decreased, as you can see in blue, the in-person visits and increased exponentially those telehealth visits that you can see in the line in gray. As we progress through the pandemic, we have shifted kind of about in May to where telehealth visits have started to decrease and in-person visits have increased. And as of August, end of August of this year, really majority of our patients were being seen in person. During the whole kind of April into May, we were reserving our inpatient visits to just those sick visits and reserving telehealth for our routine care visits. It'll be really interesting to see what happens later on in this winter with flu season. What does it look like with the COVID-19 pandemic? What are the numbers? Are we going to see a pivot back towards an increase in telehealth versus in person? I think more to come. It's ever changing and evolving. So for our pediatric pandemic care model, kind of as I alluded to, really trying to balance those sick visits with routine visits. So our sick visits really being those in-person visits, or if we highlighted any particular pediatric patient that was at risk from a nutrition standpoint, that we really needed to see them in person to get vitals, weight, on our scales to kind of identify a course of action. And again, those well visits being strictly through telehealth. So our pandemic care model for pediatrics, so before COVID, really, Monday was inpatient team rounds, no clinic. Tuesday through Friday was for pediatric pulmonary clinic. I failed to mention earlier that for our CF patients, they are intermingled between asthma, chronic lung disease, other pulmonary referral patients. So we don't have dedicated CF clinic time. So again, for this model in the pandemic, it was an intermix of CF with general pulmonary patients. So Monday afternoons, we had add-on clinic for all providers, and this was really reserved for inpatient sick visits. Tuesday, Wednesday, and Thursday were for telehealth visits, and we had no more than 2 providers in any half-day clinic. And again, Fridays was left for add-on clinic for sick visits or any other individual you may need to see in person. Just as in the pre-pandemic model, as the pharmacist on service, I would round with the attending for any pediatric patients that were admitted for an acute pulmonary exacerbation. So our pandemic care model specifically looking at telehealth, so that all visits were an hour in length. And one of my favorite parts as the pharmacist was the level of collaboration we had as a multidisciplinary care team. Really, the patient was at the center of this model. The nurse coordinator, the respiratory therapist, the dietitian, the pharmacist, and provider were all on this Zoom telehealth visit at the same time. We each had our dedicated time to interact with the patient, to ask our questions, but I really enjoyed the level of collaboration because if the respiratory therapist quizzed the patient on order of treatments, I could reinforce that as the pharmacist. The dietitian and I could really play off each other when it comes to appetite, ensuring pancreatic enzymes are an appropriate dose. And given this whole time period, the provider was actually listening in on the visit. So they knew as soon as it was their dedicated time to interact with the patient that they knew everything going in, could reevaluate, reassess, ask specific questions as need be. The social worker, as you can see, is kind of this outside bubble. And she was responsible for coordinating and scheduling all of our telehealth visits. And in that coordination period, she would interact with the patient and or caregiver to assess for any needs, whether it's financial or socially, in light of this pandemic, that we could provide any kind of resources or provide them with those tools to be successful. In our current state, if you recall that figure looking at our in-person versus telehealth visits, so we have transitioned to this period of the majority of our visits are in person. So how does that look like for our clinic structure for a 5-day week period? So Mondays, again, always dedicated for inpatient team rounds, and Monday afternoons, again, for telehealth visits. Just as in the pandemic and now in this continued pandemic model, that has changed, we are seeing CF intermixed with general pulmonary patients. For Tuesday, you can see again in the morning we have 3 providers that may be seeing patients in person, 2 in the afternoon. And as the schedule progresses, again, 2 or 3 providers potentially in any half-day-a-week clinic with 1 dedicated provider all day on Fridays. Telehealth visits could really be scheduled at any point for these patients throughout the week at the patient request. If they felt comfortable and wanted to come in, by all means, we would see them in person. But of course, if they had their concerns, a telehealth visit was very much appropriate, and we would work that in for any given day. I do find that in light of this pandemic, many of our patients that have been spending time at home coming to clinic was kind of their outlet from a social standpoint, that they could have interactions with their care team and knew it would be in a trusted setting from an infection control standpoint. Again, for our model, registration occurred, didn't really change. These patients were roomed immediately, whether we were in the pandemic or not, from an infection control standpoint. They were triaged by a dedicated CST. Again, individual time with the respiratory therapist. We did try to capture for all of our CF patients, if they had had a routine visit via telehealth, that we would get spirometry. But of course, if they were displaying any signs and symptoms of infection, we would do spirometry on a case-by-case basis. Again, the social worker would interact with the patient previously, but the dietitian and pharmacist would see the patient together to kind of optimize that visit time. But again, in light of social distancing, wanting to ensure infection control, we see these patients individually. The provider then follows up, next the nurse coordinator for any discharge paperwork, sputum culture collection, and then lastly, pediatric phlebotomy if it is needed from a laboratory standpoint and discharge. We're still working in our current model to get pediatric phlebotomy 5 days a week. Right now we have to coordinate Monday through Thursday for a pediatric phlebotomist on site, or the patient would have to go to our adult laboratory, which we try not to do if at all possible because we don't have that as strict of infection control of the phlebotomist coming to the patient room in our pediatric dedicated space. Appointment structures haven't changed too much as they were in the pre-pandemic model, with our nurse practitioner visits being anywhere from 40 to 60 minutes. Still trying to loop in those transition visits when we can, spreading those out throughout the whole week, not just leaving those for Thursdays as it was previously. Our MD visits still be in for 40 minutes. And again, very similar, each member of the multidisciplinary care team will see the patient, report any concerns or needs to the provider, but again, doing that more on an individual basis to ensure infection control and social distancing. Again, sick visits, respiratory therapist, pharmacist, and/or the dietitian.
For the adult side, we have adopted this new workflow that went into effect when telehealth services became available, and we have kind of stuck with it in current state. So we've had less of the back and forth. We've had a lot of patient satisfaction with telehealth visits and a lot of patient requests to continue them. So we have, as you can see on this same sort of chart as we showed for the Pediatric Care Center, similar timeline where April is really when telehealth took off and our in-person clinic visits were much less, just those who were sick and needed to be evaluated. And as time has gone on to current state, we are back up to having more in-person clinic visits per month, but we're still maintaining pretty strongly with our telehealth services. Now, I think the peak up for August is due in part by the fact that we had done all of these telehealth visits, and finally in August we became more comfortable bringing people in. We're very concerned about what will happen with winter and what will happen with the timeline with COVID. So we did want to get patients in that needed to be evaluated, to get spirometry, to get labs. If they were already leaving the house to go to a lab, they might as well have come in to see us. So I think that we're going to see this peak from August kind of downtrend and get to more of an equal 50-50 split with our telehealth and our in-person visits. We just had this burst in July and August of people feeling comfortable coming out and wanting to be seen. For our current model, we did restructure our week. We still do our Monday and Friday morning team rounds. We do the bulk of our in-person clinic visits still on Mondays and Wednesdays, but we've transitioned our Tuesday to be dedicated to telehealth, as well as our Thursday afternoons and Thursday morning. Even if we have multiple providers, we can have one person in clinic seeing our Brookfield area patients if there are any, and then we can have our other provider doing telehealth. And then on Fridays, we mostly stick to telehealth, but we do still see some sick visits of people who need to be assessed in clinic. For our telehealth, our structure has been that our central scheduling team emails out patient instructions and consent forms within 24 to 48 hours of the patient's appointment. And then when they sign on, our nurse obtains their consent to participate in telehealth and obtains any vitals that they may be able to take at home. So if they have a thermometer, a scale, a blood pressure cuff, we will obtain those measurements if possible. Next, our social worker will jump on and usually try to have a one-to-one interaction without anyone else in the room. Sometimes the provider may stay on if there's no sensitive topic matter for that day. For the most part, we do try to give our social worker that dedicated one-on-one environment so that patients feel comfortable opening up to them. One thing that is nice, and we'll talk a little bit more about extensive education in the setting of telehealth, but as Elizabeth mentioned, we do each have our own HIPAA Zoom link. So we have utilized the fact that we can jump on, talk to the patient during their appointment. And if we know for sure we need to talk to them more in depth later in a one-on-one setting, we can schedule out that appointment for the patient with us at a later time. And then one change for us on our workflow, which is also a huge thing I enjoyed or continue to enjoy with telehealth, is that the dietitian and myself would go into the telehealth room together if we both needed to see the patient at that visit. And most of the time, the provider would be in the room. And again, this is really helpful for reducing the duplication and not asking the patient to have to say the same thing over and over. It also is something that was necessary from a timeline standpoint because we were limited in how much time we have in the telehealth room. And as soon as the next patient's appointment was up, we had to be done. So this really helped cut down on time and duplication. And then our provider would see the patient, and if the patient had home spirometry capabilities, at that time, if they had not already done that, the provider would ask them to do that while on the line. Our appointment structure in clinic did change. Our nurse practitioner maintained 1 hour long appointment slots, but our physicians also went to 1 hour appointment slots. We really did this to try to avoid having a lot of people in the waiting room. We would, pre-pandemic, have usually 1 to 2, maybe 3 patients in the waiting room at a time. And so we wanted to avoid anyone having to be in the waiting room together. We wanted to really be able to room people immediately. So we decided to limit to a max of 8 patients per day. And this was really helpful because I think it gave our patients that comfort level that as soon as they get there, they're coming in a room and they're safe, not going to be exposed to a lot of other people. We also took the appointment times and made our nurse practitioners' appointments start on the hour and our physicians' appointments start on the half hour to try to give us that buffer that 2 patients should not theoretically be in the waiting room at any given time waiting to register. Our telehealth visits were also all 1 hour time slots. And I already sort of mentioned our multidisciplinary workflow did change a little bit with the dietitian and myself meeting with the patient together rather than individually as we do in clinic. In clinic, we've maintained a pretty similar workflow. However, we will sometimes still collaborate and go in together. So with all of this telehealth stuff kind of hitting us all at once, as Elizabeth mentioned, we had telehealth capabilities within the University of Kentucky. However, we were not specifically utilizing these in our CF clinics. So there has been a huge impact to care, and a lot of it's positive, but we still do have some limitations that we have to deal with. As far as the strengths of telehealth in our clinic, we've seen patients have less expenses, so they're not having to travel from 3 or 4 hours away. They're not having to stop and get meals in some cases. So there is less expense for the patient in that regard. And it's also quicker for our patients. The appointments are quicker since we're not necessarily waiting for the patient to get spirometry and get roomed and make it up from the parking garage. But it's also less time commitment for the patient as a whole because they don't have to factor in that travel time. And so we've seen a lot of satisfaction from the patient standpoint because we've been able to have late additions to the schedule. If somebody calls and they're available right at that minute and we have the availability to see them, we can say, hey, sign on to telehealth now and we'll go ahead and see you. We've also been able to obviously limit the exposures for our patients and staff, but also eliminate or at least reduce the need for childcare for patients who have children or that interference with work and school. One of my favorite strengths, though, of using telehealth has been that it really puts the patient in their comfort environment. So we've had patients give us tours of their houses, introduce us to their pets. It's just really been good to see them feel a little more comfortable in that environment, and I think it's really helped us build even stronger connections with them. And from a pharmacist standpoint, I enjoy the fact that if a patient doesn't know the dose on one of their medicines, I can say, go up to your medicine cabinet, get the bottle, and let me see it. So I think we've had a lot of improvements in the accuracy of medication lists, especially with supplements or over-the-counter things that patients may take. So that's been really good from my standpoint. But as I mentioned, we have some limitations that we need to deal with. So some of these barriers we have found ways around. Some of them we're still working on. So we do have time restrictions. As I mentioned, all the patients who see our physician, for example, are going into the same clinic room, digital room, so to speak. So we do have the limitation that when that hour time slot is up, we have to be done because the next patient needs to be admitted into the room. So there are some time restrictions from the standpoint of needing more intensive counseling or education on something. There have been also some technological limitations. I'm sure you've all seen this as well, but we have a lot of patients that live in rural areas and may not have good cell phone connections or internet access. And we do have a cohort of patients who don't have the necessary devices to be able to do a telehealth appointment. It's been limited as far as lack of patient acceptance. For the most part, people have really latched onto telehealth and enjoyed it, but we do have some who, either because of lack of experience or concerns that it's not fully private, who have not accepted this form of medical appointments. And then obviously the big one is this difficulty in obtaining monitoring parameters. We are so used to seeing our patients in clinic every 3 months and getting everything we need from PFTs to imaging to labs to sputum samples, that this has really been something we've had to find a workaround and become comfortable with not knowing some of these things. So we've had patients that maybe haven't had a PFT in 6 months, and we just have to kind of let go and become comfortable with the fact that we need to assess their whole person and not just focus on the numbers. So we have identified here some best practices that have helped us overcome some of these barriers, and we're going to focus on just a few of them. But the first of which will be patient education, then we'll talk about home spirometry use and our approach to laboratory monitoring. Patient education is a huge component of my job. Counseling is a huge component of our social workers' job. So as far as needing dedicated time one-on-one with the patient, telehealth time restrictions have really made that difficult. So from my standpoint, if I have a patient starting a new medication or who has extensive adherence issues that need to be addressed, I can't really do those within the time that I'm given for telehealth. And for our social worker, she may not have enough one-on-one time to feel comfortable bringing up sensitive topics. So we have really utilized our HIPAA protected Zoom links to meet one-on-one with patients at a later date. I think it helps from a lot of standpoints because we're able in this environment to allow the patient not to get so overwhelmed, where in their appointments we provide all this information all at once. We're able to kind of break it up at their convenience, and they may be less overwhelmed when we tell them new information. So I've utilized this a lot for new educations, and it helps not having that time restriction. I like being able to share my screen and conduct my education just like I would in clinic with the resources and tables up for the patient to see along with me. One of the best aspects has been the patient being able to have medication in hand and even witnessed first dose administration. This has been particularly helpful with inhaled medications and some of our dry powder inhaler forms that are more complicated to use for inhaled antibiotics. I've been able to actually have the patient in front of me with the device in front of them and take their first dose and give them feedback on how their technique was. I do want to just mention we are not currently billing as multidisciplinary team members for these services. So I'd be really interested to hear in the pharmacist listserv or in the discussion boards if other people are doing similar things and billing for their services. I'd be interested in learning more about how that's taking place. Home spirometry is something that, similar to telehealth, we had pretty minimal use before the pandemic. And so our post-telehealth implementation has caused us to have more of a need and desire to have home spirometry. So we're lucky that the Cystic Fibrosis Foundation has worked with ZephyrRx to distribute home spirometry to percentages of our patients here in clinic. But this also comes along with some new challenges. We need to figure out how to educate patients properly about the device, how do we follow up on results, and just from a clinical standpoint, what's the utility of having these numbers? So if you haven't already seen this article, the eICE study results, I would urge you to look this one up. In a nutshell, this study looked at using home monitoring with home spirometry in CF patients, and they found that the intervention of home monitoring didn't necessarily slow the decline in lung function, but it did allow us to detect exacerbations earlier and treat those earlier. So in the long term, there really could be a lot of benefits to the patient's overall health, as well as time missed from school, from work, et cetera. So I think it's something we'll learn a lot more about now with home spirometry being a bigger component of all of CF care. But as far as the barriers, I think in an ideal world, we would have either telehealth or clinic-based education and demonstration of the device. We'd be able to help the patient troubleshoot and set up the applications for use and just have that initial touch point. In addition, on the pediatric side, the respiratory therapist is beginning scheduling Zoom appointments with the patient on those protected Monday afternoons to kind of review how their home spirometry results were, did they have any difficulties with the device, and just giving us that touch point. From the adult side, we're still trying to figure out the best workflow. We need to figure out the comparison of the home spirometry versus in-clinic spirometry. So one thing we've been doing in the adult clinic is when the patient gets their home spirometer, the next time they're in clinic, we ask them to bring it with them. When they perform their in-clinic spirometry, we have them also use their home machine so that we can try to get a comparison to see, are those numbers the same or do they vary by a certain percentage? This gives us a better idea of how that patient, their technique or their ability to produce a reliable home spirometry number will be. And for all patients, this is going to be different. So we have some patients who have matched up perfectly and we feel really good about those results, but then we have others who are up to 10% difference, and some are higher with the home spirometer, some are lower with the home spirometer. So there doesn't seem to be a specific rhyme or reason to this, but it helps us to know that, you know, we need to focus more on the trend than the exact number in most of our patients, and educating them about not panicking if they have a lower value until they really know what their home machine baseline is will be really important for reducing our patients' anxieties. And then one thing that we have not done yet, but we are actively needing to discuss in both of our clinics, is utilizing some sort of action plan. So just like with our asthma and COPD patients, we should be able to develop some sort of home autonomous action plan for our patients to know when should they increase their airway clearance therapies, when might they use antibiotics on hand if they're a patient that we think can handle making that decision, when should they call clinic or seek care through emergency services. So I think in the future of CF care, we're going to see a lot of CF action plans, and I'm really excited for that phase because I think it will help our patients feel more in charge of their care.
And after these two kind of best practices that we've introduced, you know, laboratory monitoring is another one of those things that we've been battling, especially with the approval of these highly effective modulator therapies. Just right before the pandemic really got started, end of October, we all know Trikafta was FDA approved, and through end of October, even in the first of the year, a lot of our patients were getting started on this therapy. And within that first year, we have to consider those frequency of, you know, hepatic function monitoring. Per package labeling, every 3 months is what's required. So as a care center, really balancing, do we allow a grace period? Do we go beyond a 3-month interval? Do we go 4, 5, 6 months in between LFTs? For both adult and pediatrics, we really settled on this maybe 1 to 2 month grace period for our patients that need hepatic function panel monitoring, being on Trikafta or any other new start modulator therapy. And some of our considerations is, are we going to use that in-house laboratory facility that we have here at the University of Kentucky? Do we limit those for in-person visits? Do we try to partner with our patients that live more locally to come in-house so we have readily available in our EMRs those lab results to evaluate and triage appropriately? But one of the big things that we've had a battle with our patients that are strictly doing telehealth, that live more rural, that are not local, are these outside laboratories. And for the pediatric and adult centers, we've really tried to develop this model of what can we do to make sure the patient feels safe and healthy if they do venture outside the home to get these labs, when it has been maybe that 1 to 2 months since they last had or were last due for their LFT monitoring. So one of the workflows that we've established is during that telehealth visit, asking the patient, what is that local laboratory for you? What's most convenient, whether it's a primary care provider's office that has laboratory capabilities? Is it a local hospital that they could go to, or other kind of clinic space? The nurse coordinator or the pharmacist would then call that local laboratory. They really we're trying to inquire about those infection control measures. So what are you doing to keep the patient safe and healthy? Are they calling when they get there? Do they stay in their car until they receive a text message or a phone call from the nurse or other member of the laboratory team to let them know now it's safe to come in, making sure you have your mask on and different things? This really helps to ease our patient's anxiety. So after we gather that information, then as the nurse coordinator or pharmacist, we're touching base with that patient or caregiver to really let them know and outline those steps that are in place that will keep them safe and healthy. And during this time, we're also going to discuss with the patient of what that timeline is. You know, maybe we are at that 3-month period when they have their telehealth visit, but really aiming to try to get in the next month or so, venturing out to that lab to be able to get that blood work completed. Depending on the patient and their circumstances, either we would fax those lab tests to the laboratory or actually email those test orders to the patient to take. Throughout this process, given everything being in this digital or outside kind of environment, there's a lot of ongoing follow-up and monitoring that is needed until we receive those results in hand. So we're constantly flagging ourselves with our internal task boxing system to flag when these patients were expected to go get their labs completed, when should we be expecting results, calling the lab just to make sure nothing has changed as far as their capabilities to perform the testing that was needed, and just following up, most importantly, with the patient to make sure their comfort level hasn't changed in light of increasing case numbers of COVID-19 or various other things that is prohibitive for them to go get these lab tests done. We have been very successful in obtaining a lot of the necessary labs for our patients, and again, recognizing we may have this month or two extra lag of time in between these hepatic function panels, but luckily our patients have been safe and healthy, and we haven't had any new ADRs that have been reported because of this lag. And I know there's been a lot of conversation and dialogue on the pharmacist listserv and other multidisciplinary listservs about how to handle these patients in light of the COVID-19 pandemic and these laboratory needs. So I think we've really highlighted a lot of what our care center is doing as far as pre and post COVID-19 pandemic, sharing those best practices, those strengths, those areas of limitation when it comes to telehealth visits. I know our center, both pediatric and adult, is just one way of doing things, and it was exciting to be able to share what we've been doing, how we've adapted in light of this. But we definitely want to hear from you guys. So share those best practices on the pharmacist listserv, or if you have any specific questions as it relates to our presentation or any questions about how we've adopted our model, do not hesitate to reach out. Our email address is listed there. Thanks, and enjoy this virtual CF conference.
Hello, and welcome to our presentation of Justification of CF Pharmacy Services. My name is Emily Dufek, and I'm a pharmacy technician, and the rest of us will introduce ourselves as we go.
Hi, I'm Kim Ehlert. I am the pharmacist that works in the adult clinic at the University of Minnesota.
Hi, I'm Rachel Espinosa. I'm a pharmacist who works primarily in the pediatric clinic, but I also cover the adult clinic at the University of Minnesota.
Hi, I'm Jessica. I work at Texas Children's Hospital. I'm a cystic fibrosis pharmacy technician.
Hi everyone, my name is Jenna Faircloth and I'm a clinical pharmacy specialist at Texas Children's Hospital in pulmonary medicine. I'm also a part of our Baylor College of Medicine Pediatric Cystic Fibrosis Center.
Hello, my name is Erin McDade. I am the Assistant Director for Clinical Pharmacy Services at Texas Children's Hospital, and I'm also one of the clinical pharmacy specialists for pediatric pulmonary medicine at Texas Children's Hospital and work closely with the physicians from the Baylor College of Medicine CF Center.
So I'm going to kind of introduce our topic here and get us started. None of us have anything related to this program that we need to disclose as far as financial relationships. Our objective today is pretty simple. We just want to identify methods to obtain and sustain funding for pharmacy personnel dedicated to CF care. So we're going to kind of take a look at how we did this in Minnesota, how they took care of this in Texas, and then some of the similarities and overlap, and then a few of the differences as well. So we'll start with our Minnesota experience. So as you can see, we have our lovely snow slide here. This is actually the road to our CF clinics, and this is what it looks like 9 months of the year, and I wish I was kidding about that. But as you can see, we have these 3 snowplows here, which I like to think are myself and Kim and Emily kind of paving that way and getting into the CF clinic and doing what we need to do to take care of our patients. So we kind of started out, all 3 of us had specialty pharmacy experience within the health system. Kim and I were both working in a pharmacist role supporting disease states such as cystic fibrosis, and then a few other rare diseases as well, to the patients that use the Fairview Specialty Pharmacy. And then Emily was actually in a technician role at that pharmacy, which they call a patient financial advocate. So basically what that role means is she had a hand in securing funding through prior authorizations, patient access programs, manufacturer copay assistance programs, anything they needed essentially to get those copays reduced. Emily had experience doing that just within the specialty pharmacy. In 2017, we were awarded the Foundation Pharmacy Grant to kind of increase outpatient pharmacy services in our CF clinic. So we added a PharmD in the pediatric clinic first 3 days a week, which was myself. And Kim started out 3 days a week in the adult clinic. And then we had Emily start to kind of cover both clinics full time. So she was 5 days a week. We did this for a few months. And then in early 2018, we actually found a need to expand, especially in our adult clinic where we do have pretty busy clinics 5 days a week. And I expanded my role to be 3 days pediatric and 2 days in the adult CF clinic. So some things we do, Kim and I do report to our medication therapy management department. So we are not technically reporting to the specialty pharmacy or the inpatient pharmacy. It's a separate sort of ambulatory pharmacy service that we have here. And so medication reconciliation is a big thing. This was kind of one of the first things we tackled. It's an easy thing to take off of people's plates in CF clinic. We collaborate with the interdisciplinary care team to create care plans for patients. So, choosing the best antibiotic, choosing the most appropriate CFTR modulator, and a whole host of other things we're involved with. We do assess and manage any drug-drug interactions, as any pharmacist would. We assess patient and parent understanding of medications. Sort of in the pediatric side, it's more of the formal transition process, which we start at age 4 and continue until they transition to the adult side. And then sort of in their early adult visits as well, we're sort of checking in on that to see okay, do they know what their meds are for? Do they know how to refill them? Do they know what to do if they can't refill them? All those sorts of things. We assess access and adherence at every visit, just making sure, number 1, can the patients get the medication? And then number 2, as long as they can get the medication, are they able to take the medication and take it appropriately? We manage the CFTR modulator monitoring. This has become kind of a big task for us with Trikafta. We have a little over 300 patients at our center taking it. And so a lot of LFT monitoring, especially in this first year where it's quarterly, and sort of a lot of follow-up on that. And I think that's been a big thing that our team has really appreciated. It's something we can sort of take on and manage and own and make dose adjustments as necessary. But it's definitely been a big time-consuming task as well. Another thing we've kind of done is we do this proactive assessment of CFTR modulator treatment choices. This was more of an issue before Trikafta. Now it seems like if you have a copy of Delta F508, and you're over 12, there's probably no reason not to use Trikafta, maybe sometimes. But the providers really appreciate having the note in the chart prior to the visit so they know, are there any drug interactions? Do they need to dose adjust anything they need to be thinking about as far as cost-wise for the patient that might influence their decision of which modulator or when to start a modulator. We provide patient education, new meds, ongoing meds, anything they can think of medication related. And then we communicate with our specialty and retail pharmacies to try to overcome any access barriers for patients. In the pediatric side, I do all of the hospital discharge teaching. So if a CF patient's admitted and then they are going to go home, I make sure I do all the discharge reconciliation, coordinate getting meds up from the discharge pharmacy or sending from the specialty pharmacy through their home, and kind of helping with any maybe IV to PO switches that need to be done on an outpatient basis as well. And then, like I said, we prepare the pediatric patients for transition to adult care. I think pharmacy is a big hurdle for patients as far as that goes. And so they just need a little extra help kind of figuring out how to navigate those special pharmacy areas. And with this, I'm going to turn it over to Emily to talk a little bit about her role as a pharmacy tech.
Hi, my name is Emily Dufek. I am the pharmacy technician for the University of Minnesota Cystic Fibrosis Center, both adult and pediatrics. I wanted to talk about my role a little bit. One of the things that I do, probably the main thing I do lately, especially with Trikafta being released, is I complete prior authorizations with the insurance, and I also do the appeals as well. I even write my own appeal letters, and my doctors, they're all okay with that, and I just send them off and actually have a pretty good approval rate. One of the other things I do that's really helpful is processing test claims. That way I know exactly if it needs a prior authorization, if it has a high copay, I can address those issues as well. And then moving on from the test claims is then I enroll them in the copay card, and we also do enrollments in Health Well grant enrollment too. Another big part of my job is patient and team member education. So I am kind of the expert on all things insurance when it comes to the pharmacy part. And so I definitely help our patients understand their plans a little bit better and what certain things mean. And then I also help our team members as well. because sometimes doctors just don't understand that the insurance doesn't cover things. Another part of my job is I do free drug enrollment. So if the patient can't get access to something due to insurance or lack of insurance, I will help them with that as well. I do meet with patients in clinic when we are not going through a pandemic, and I actually really look forward to meeting with them again. I do miss seeing them in face-to-face meetings. I do also track the HealthWell renewal dates, so that way no one really goes without having that coverage. I'm part of the patient and caregiver advisory boards, and then I also help train our staff at our pharmacy as well in CF. If a new person comes on board, I have a little CF one-on-one presentation that I give them every time, just so that they have a good understanding. Next slide, please. So we do definitely have some pharmacist and pharmacy tech overlap that we do, and that comes with assisting with medication access concerns and coordinating those access interventions. I work with two amazing pharmacists on our team, one for adult and one for pediatrics, with Kim and Rachel, and we definitely both share these responsibilities. I am also, with the pharmacist, a member of our CF quality improvement team. So we meet every week to work on different things to make processes go a lot smoother in clinic. I do also attend the weekly CFT meetings with the whole team. We're definitely subject matter experts for our health system specialty pharmacy because I am probably have the most expertise in CF for a pharmacy technician. I definitely help provide that education to our multidisciplinary team member. And with that, I'm going to hand it off to our Texas children friends.
Thank you, Emily. I'm going to take it away from here and talk about the Texas Children's experience and our road to pharmacy services for our ambulatory CF patients. Our road to pharmacy services in Houston at Texas Children's Hospital is similar to the road in Minnesota, except you can see in our picture that instead of plowing through snow, we often are forced to trudge through floodwaters. And so we trudged through those waters and successfully came out the other side. And I'll give you a little bit of explanation of how we did that. So in about 2011 through 2016, we had one inpatient clinical pharmacy specialist, myself. Like I said, I focused on inpatient management of pulmonary patients with a focus on cystic fibrosis management, but also assisted in the clinic as needed on a consult basis, but didn't have any true recurring physical presence in the clinic setting. In October or November 2016, we were fortunate enough to receive the first round of grant funding for implementation of pharmacy services in the CF clinic. At that point, that allowed me to transition my role from predominantly an inpatient role to a more ambulatory role. I still did provide inpatient services and rounded several days a week, but also provided services in clinic on a more consistent basis. Over the course of those 2 years, we also opened a specialty pharmacy at Texas Children's Hospital. And through partnership with the specialty pharmacy, instead of hiring a new clinic pharmacist for the specialty pharmacy for the CF patients, I took on those roles as the clinic pharmacist for specialty and helped enroll patients, monitor adherence, do assessments, and all of the requirements for our specialty pharmacy. Through that collaboration over the years, I was able to demonstrate that I had benefit to the specialty pharmacy through enrollment of patients and increasing margin through the specialty pharmacy. And in May of 2018, we were able to secure funding for an additional clinical pharmacy specialist to join me. And that clinical pharmacy specialist, Jenna, is funded by the specialty pharmacy through that collaboration that I described. And then a year later, we were very fortunate to receive grant funding for a pharmacy technician through the CFF. And Jessica joined our team, and we couldn't be happier that she's with us. And she is partially funded through the grant and then also partially funded through our specialty pharmacy. And again, we collaborated with our specialty pharmacy to really work with them and pose this opportunity as a pilot for clinic pharmacy technicians in other specialty clinic areas and settings. The pharmacist role at Texas Children's Hospital is similar to Minnesota with a few differences. Our clinical pharmacy specialist, Jenna, and myself are present 5 days a week in our ambulatory clinic, divided between the two of us. We still provide inpatient services, which I think is probably the biggest difference between us and Minnesota. And we run an inpatient team about once a week. We focus very heavily on quality improvement and research initiatives with the Baylor CF Center physicians. And we actually co-chair a CF pharmacotherapy quality improvement team, which is one of the things that is the physicians at Texas Children's really enjoy. We also, a difference between us and the Minnesota group is we report through the Texas Children's Hospital Pharmacy Department instead of the specialty pharmacy.
Hi, I'm Jessica Ferdinand, the Cystic Fibrosis Pharmacy Technician here at Texas Children's Hospital. My role is newer than Emily's at Minnesota Hospital. I've been in my current position since early October of 2019. In the beginning, my key responsibilities was to perform prior authorizations and appeal management for CFTR modulators, inhaled antibiotics, and non-cystic fibrosis medications for the Texas Children's Hospital Specialty Pharmacy. Later in October of 2019, Trikafta became FDA approved. My team and I collectively agreed that I should be the primary person handling all prior authorizations and appeal managements for Trikafta to better streamline insurance approval processes. Along with that, I've helped patients and families enroll in GPS Vertex patient assistance program. One of my biggest roles that is appreciated by the CF team is my collaboration with other specialty pharmacies. I provide PA approvals for all modulators. I help coordinate refill request approvals and check on the status of medication deliveries for all specialty pharmacies. Lastly, before COVID, I met families and patients in clinic to help enroll in Vertex, Healthwell Foundation for treatments and vitamins, and help coordinate medication deliveries for both Texas Children's Hospital and other specialty pharmacies.
Thanks, Jessica. My name is Jenna Faircloth, Clinical Pharmacy Specialist at Texas Children's Hospital again. And I wanted to now walk y'all through some key steps in securing pharmacist and pharmacy technician position funding. Kim is going to delve into this some more later on in the presentation, but wanted to share with y'all some key steps that we learned through our experience specifically here at Texas Children's. So first, that was super key, first big step into this journey of securing funding was collaboration with other cystic fibrosis pharmacists and learning from their experience. So we're very blessed to have a network of CF clinical pharmacists who had started trailblazing at their own institutions, and we were able to glean what they learned and how they were successful in accomplishing this. We want to really encourage everyone to reach out to our network and utilize this amazing resource that not all pharmacists and technicians have. So we really encourage you to do that. Another key step is justifying the position with both clinical and financial outcomes. So we focused on two specific ones. The first one was increasing revenue, and the second one was reducing hospital admissions. So more specifically about increasing revenue, this was increased revenue for our Texas Children's Specialty Pharmacy through increased capture of CFTR modulator prescriptions, through the CF clinical pharmacist involvement in the CF clinic. They would be able to enroll more patients, which would lead to more patients and more prescriptions being filled of a CFTR modulator or other specialty medications, which translates into increased revenue for the department. And looking at standard reimbursement rate for the estimated population that would be enrolled, this far exceeded the cost of that FTE. Next, so speaking a little bit more about reduced admissions, so reduced hospital admissions through increased adherence to specifically inhaled anti-pseudomonal antibiotics, resulting in cost avoidance. So this reduction in adherence-related admissions would result in a decreased cost to our entire health system, as many patients had an insurance plan through as many patients do have an insurance plan through our hospital health plan. The next step on this journey was leveraging existing relationships with pharmacy department leaders and executives. By having those relationships built, it provided the ability to have additional conversations and executive level presentation opportunities to gain support and buy-in for the worth and the value of this CF pharmacist position. Another key step is going to be defining your discrete metrics early on and then determining a feasible and efficient way to track them. At Texas Children's, we've developed a flow sheet that has discrete fields in them to demonstrate and track Aaron and I's activities. And prior to the flow sheet, it was manual review of notes in the chart and very time-intensive process and more difficult to really summarize that data when you need it quickly. So the flow sheet has allowed more efficient tracking. However, your tracking method could be as simple as an Excel spreadsheet. Kim's going to dive into this piece a little bit more later on in the presentation. Most important takeaway, we learned that you want to define what you're going to collect and start collecting as soon as possible. The last most important step we wanted to share with y'all from lessons we learned through our experience is just setting out and determining what the path for your justification is going to be at your specific institution, because this can widely vary, honestly. Institution to institution. At ours, specialty pharmacy was the avenue that was best for us, but at your institution, it could be if you're a specialty pharmacy, or if you don't have a specialty pharmacy, the pharmacy department, or or even the pulmonary department, the CF center. There may be many options, and the earlier you start, the more time you'll have to figure that out and navigate that. So key steps we want to share that were important in securing the technician funding. So first key step was gaining support from our CF center and clinic nursing leadership. I can't tell you enough how thrilled they were. At the moment we mentioned this position, they checked in weekly from the time we were awarded the grant until Jessica started. They were just thrilled at having this role join our team. The next step that was important, again, leveraging those relationships with our pharmacy department, specifically our Texas Children's Specialty Pharmacy Department and executives. A plan was presented to executive leadership, including the benefits, financial and clinical, of a clinic pharmacy technician, as well as proposing a plan as a pilot to other subspecialty areas. And with that, we were able to gain their support and funding the other part of the position to have a full-time position. The last key step we wanted to share with y'all was some outcomes that were important in justifying the position. So the two we selected were time given back to nursing and the nursing and physician satisfaction. So the satisfaction was completed with surveys, and time given back to nursing was completed with a combination of retrospective chart review of notes. We actually have we're going to be presenting this data here, abstract 543, so feel free to stop by and hear more about that. Now I'll turn it back over to Erin to talk about some overall takeaways.
Thanks, Jenna. I'm going to step in and talk about some overall takeaways for both the Minnesota and Texas Children's Hospital programs. So high impact areas for pharmacy technicians and pharmacists. And we know this isn't the objective of our talk today, but we would be remiss if we didn't provide a little insight into where we think the high impact areas are for both of these roles. For the pharmacy technicians, we found a huge benefit for the technicians to assist with prior authorizations, as well as enrollment in copay assistance programs, HealthWell, Vertex GPS programs, and many other programs. Not only has the CF Center and the pharmacists found this beneficial, but also the patients have expressed a lot of kind words to our pharmacy technicians for assisting them in that process and helping to decrease the financial burden of their medications. The Minnesota program is a little bit more mature than the Texas Children's Hospital program and has begun to do a lot of work in the test claims and benefits investigation by utilizing technology that we haven't necessarily adopted at Texas Children's yet. But it is something that we hope to be able to do in the future. From the pharmacist perspective, big impact areas are interventions that are related to improving adherence and access to medications. As we all know, if a patient doesn't have the medications at home, they can't be adherent. And if they aren't adherent, then they're likely to be admitted. So what's been shown over time by other groups as well is that improving adherence can have the potential to decrease admissions. Both the Minnesota and Texas Children's pharmacists play a big role in selecting and monitoring medication regimens. This is especially true for antibiotics during pulmonary exacerbations or antifungals when necessary. And then additionally with CFTR modulators, we both provide a lot of education to our patients and providers about these medications. We assist with complex medication regimens. So for patients who have comorbidities that the pulmonary team isn't necessarily comfortable managing or assisting with those medications, we help and step in and educate them and help provide some support for the management of those medications. And then lastly, I've talked before, we both play a big role with quality improvement and standardization of care at our CF centers. Some challenges that we faced are, it can be difficult at times to balance the needs of the CF center with the needs of the pharmacy department. So you might sometimes feel like you're being pulled in several different directions. One thing obviously that we're here today to talk about is how to justify your position beyond grant funding. And while this is a challenge, we do have some suggestions which we hope you'll be able to take away from this talk. And the big takeaway is that you need to do a little planning before you even start your role in the clinic setting. Think about things that you want to focus on, what types of interventions you want to focus on, how can those interventions be tracked, and set up your system in a way that will allow you to track those easily. So whether it's in your notes or creating discrete flow sheet data to help you pull that data when you're done with your grant to show really what you've been able to do for the patients and the institution. And that goes along with demonstrating your value in a tangible way. So really the important part is tracking data and then sharing that data with the leadership team that will be approving the position, whether that's pharmacy department or the CF center or the specialty pharmacy. Providing them with data is really the key to getting approval past the grant funding. And I'll pass it over to Kim to talk about key takeaways for funding.
So we'd like to wrap up with a few key takeaways that will help you as you pursue funding for your pharmacy services at your program. As we've mentioned, one of the most important things you can do is make sure that you have some documentation of your interventions and patient care activities that you've been completing to really help show the value of what you bring to the care of the patients and to the team. Ideally, the easiest way or the most efficient way to do this would be to use something that's already built into your electronic medical record that will capture that data as you're doing your documentation and then be able to report that out. I realize not everybody has those types of resources available to them. So if not, just using something like an Excel spreadsheet can be very helpful to help you stay on track with documenting those different interventions and compiling data. And I would also like to say, if you are in your current grant cycle already and you haven't been doing this, that's okay. I would say at least get started now so that you have something from this point going forward to show the work that you've been doing. And it can be simple things like the number of patients that you've met with, the number of CFTR modulator education sessions you've given, hospital discharge teaching, any of those types of very concrete data will be helpful to show all of the impact that you've made for your patients. Another thing that we have found to be really helpful is to get all of those key decision makers involved and to get everybody to sit down at the table together and talk. Over the years, we've had several meetings, I would say probably at least once a year, with our CF Center directors and our pharmacy leadership and pharmacy directors. And that's been really, really valuable. It can be a challenge, of course, to coordinate the scheduling and to find a time where everybody can meet. But I think that it's really helpful to have all of those key decision makers and the stakeholders in the room together to talk about the role of the pharmacist and the pharmacy technician and why they are so important and necessary. Another thing we've talked about a lot is if you have a health system specialty pharmacy to work to capture as much prescription volume as you can to help generate some revenue for the health system. Even if your pharmacy doesn't have access to Vertex drugs or some of the other limited distribution drugs, look at the other specialty medications that you would be able to fill. And in addition to that, I would really explore some of the other non-specialty medications that CF patients are taking. If you look at a lot of the other common medications that our patients are on, such as pancreatic enzymes, inhalers, insulin, and diabetic supplies, I think that there are some other opportunities for some revenue to be generated by filling all of those prescriptions as well. And, we found that a lot of our patients find that helpful too, because a lot of the typical retail pharmacies don't carry those medications, or they don't have the sufficient quantity on hand, and patients are having to take multiple trips back to the pharmacy, or they have trouble finding the vitamins that they need. So really looking comprehensively at all of the medications that your pharmacy could fill for patients would be a good idea. And the last thing is to really make sure that both the pharmacist and the pharmacy technician are really fully integrated into and involved with the CF team. It's hard for a lot of people working with a pharmacist or a pharmacy technician in a clinic is a new thing. And so it's really on us to show the team what we can provide and how we can help out, and not necessarily sit and wait for somebody to give us something to do or ask us to help. When I first started in our clinic, one of our pulmonologists, one of the very first days I was there, he said, "Really glad you're here, Kim, but I have no idea how to use you." So you do have to be a little bit proactive and really working to make sure that people see you as part of the team. I know I've learned a ton from my teammates, working with them side by side. I've learned a lot about cystic fibrosis and learning about what other team members do and how I can help them. There is a fair amount of overlap between the disciplines. So it helps to really, talk not only with your center director, but the other people on your team to find out what you can do, kind of what their pain points are, where the needs are, to be part of that team. And I think this is also where opportunities like being involved with quality improvement or other projects, volunteer, jump in, offer to help out, because that really helps to really further integrate you into the team. And with that, I would like to address a couple of questions that we had regarding this topic. So the first question, what are the advantages and disadvantages of billing for services? And this is a great question. I think this is something that has come up quite a bit for a lot of us. And so what I'd like to do is kind of speak to both the pros and the cons of trying to bill for pharmacist services. On the pro side, well, of course, you should be billing and being reimbursed for your services. What we provide is a very important and valuable service, and we absolutely deserve to have that recognized and to be paid for it. There's no other provider that would see patients in clinic and not bill for that same service. And there are some existing CPT codes that will allow you to bill for medication therapy management services. So some of those things are in place and are being used across the country. That being said, the process of trying to bill for those services is very complex and can be quite challenging. Coverage varies widely from one insurance plan to another, and it takes a lot of time and a lot of effort to understand the different billing requirements from different payers. In addition to that, you have to be familiar with different documentation requirements that different payers have, and some of that can be also rather time-consuming and difficult to make sure that you're checking all of those boxes. Some insurances will also require you to complete a certification program or a certain type of training program in order to be able to bill for those services. So it's tricky. Another big challenge is if you get into a situation where you're wanting to bill for your services and some patients have coverage for pharmacy services and other patients do not, because we really shouldn't be in a situation where you're meeting with all of your patients and seeing all of your patients in clinic and billing those patients that have coverage for those services and providing that same service free of charge to patients that don't have coverage. Most patients too, the reality is that they're not going to be interested in having any additional out-of-pocket expenses for their health care. So then you may run into a situation where patients are going to decline to see you in service. So they don't want to meet with you because they don't want to be billed for that. So that's a challenge as well. So I think that there's a lot of obstacles to this. So if it's something that you either want to pursue or you've been asked to start doing this or you've been told that you need to start doing this, you're going to need some help. So you're going to need to look at what resources are available to you to help understand those different billing requirements and the logistics of submitting the billing and receiving the reimbursement. If you have other pharmacists in your system that have been successfully billing, definitely want to reach out to them, see what infrastructure already exists. Some people are doing this by billing directly for the medication therapy management services. Other people have found some other ways around that by doing facility fees, or some people will also document within the provider's encounter, and then the provider, when they're billing for their clinic visit, take into account that additional time spent with the patient. So there's a few different ways to do it, but the bottom line is it's difficult. And I think our consensus is if it's not something that you have to pursue right now, we wouldn't recommend it. We feel there's probably better ways that you can work to justify your position and other ways that you can find support for funding for pharmacy services. So I would save that as maybe a last resort or something that you would do only if you have a lot of existing support and help with some of those logistical concerns with billing. And we have one other question that Jenna will answer for you.
Thanks, Kim. So the last question is, what if I don't have a specialty pharmacy? So this is a great question, and based on experience at a previous institution, as well as my experience in this current role, long-term justification of this position is still very feasible, even if you don't have the specialty pharmacy avenue that some of us have taken. Some things I want to emphasize that are important that have been previously mentioned in this presentation. First, identifying the key stakeholders at your institution that could provide your long-term funding. This varies widely from institution to institution based on the financial status of each of those departments and who's going to be best suited to be able to fund, and it also depends on how your organization is structured. So certainly start with the pharmacy department and approaching as an option for sustaining your funding long term, but also consider your CF center or the pulmonary department as well may be great options to fund that position long term. Working with that department to establish funding, even if you don't have a specialty pharmacy. So the second key point is going to be relationships. We cannot say this enough in this presentation. And so once you've identified your key stakeholders, work on building relationships with those staff and being present in those areas. Developing recurring meetings, introduction meeting and ongoing meetings, communicate out your wins, or even they're on the smallest scale. From an improved adherence in one patient case or saved a patient X amount of dollars. I mean, sharing those small wins is just as beneficial when they're frequent as sharing it on a larger scale, which brings me to my next point. And as we've said before, you want to be sure to collect your data because it's going to be so important in justifying that position and start right away. We highlighted this earlier, but it's just so important. And it can be as simple as you want it or as grand as you want it, but just making that it's feasible and starting sooner than later. An example of something that we did here when I started my position was getting baseline data on CFTR modulator compliance with lab monitoring. So we looked at that, and our percent compliance around that time was actually very poor due to a variety of barriers. We implemented a pharmacist-driven monitoring process and created an EPIC report that helps maintain that efficiently for almost 200 patients on modulators, and have seen improvement since that process was implemented. So you could look at it showing the impact you have through something like that, improving percent compliance with particular medication monitoring. Adherence clearly is a great one, but in addition to clinical outcomes, I think it's also very important for y'all to look at making sure you're capturing and quantifying your workload and the workload that you have offloaded from other groups. That could be very pertinent information, especially in times when we have high nursing turnover or high physician turnover or other staff members. Demonstrating how you have offloaded that work from those groups and improved their work life or prevented medication delays. Your key stakeholders are going to be a lot more attentive to that information because they know that it is a group that's been stretched thin and really needs that help to continue. So something else to consider in addition to your clinical and financial outcomes. So setting up recurring meetings once you've collected your data and summarized it, and summarizing it on relatively frequent basis, at least annually we would recommend, but at minimum, annually at minimum, but also you could even consider presenting something every 6 months at a faculty meeting or at a pharmacy department specific meeting. Getting yourself positioned in there to get your work out there. So with that, good luck, and feel free to reach out with any questions y'all have as you're navigating this experience. We are more than happy to help, as well as our entire CF network. We're here for each other, and we want to to all be successful together as a group. We want to thank you for your time and attention. It really was a privilege to share our experiences, and especially from our home office or our work offices. And so we hope you have a wonderful NACFC 2020 virtual experience. Thank you.